Yeah, look, my name's Jonathan Koea. I'm a surgeon in Auckland. I work primarily at North Shore Hospital, but also undertake research at the University of Auckland. And I'm kind of an accidental neuroendocrine surgeon um, because I did my training or some of my training in the United States 25 years ago now, 25 to 30 years ago. And I trained primarily in liver surgery. So when I came back to New Zealand, all of the neuroendocrine patients, many of you know, like live for a very long time with disease in the liver, and kind of no one really understood it or knew what to do. And they kind of thought I did because I trained in liver surgery. In fact, I'd seen some neuroendocrine patients, but it's been an amazing journey for me. And some of the patients that I took over the care of 25 years ago are still patients. So, that's been a real blessing. What I thought I'd do is I've just got a few slides, I think there's 6 or 7, that I'll just talk through to show you kind of how there's a joke in this house, how surgeons' minds work or don't work, but they're kind of the things that we're looking at when we're looking at how to treat people, when to treat people and what to do. And particularly, one of the tricky things, but one of the fun things for neuroendocrine cancer is that many of the rules get broken, our normal rules for treating cancer patients, simply because the treatment's so individualized. One of my old mentors used this quote a lot. It's attributed to Samuel Beckett, as these things are, but a surgeon is he, not she. 50% of surgeons are female now, but is he who would take by force that which a gentleman would achieve with guile and strategy, which kind of is a meme of surgery, I suppose. But with neuroendocrine tumors, there's a lot of kind of guile and strategy involved in managing them because everything is so different. So these are the kind of the rules of surgery for cancer. And I don't mean neuroendocrine cancer, I just mean kind of every other cancer. So we generally like to treat the primary tumor, so the first tumor that started it all, by removing them, and usually with clear margins. And that means when the pathologist looks at the specimen, there's a 1 centimeter block of normal non-cancerous tissue all around it in all planes. So that's what we like to do. That's viewed as being kind of standard of care. We most frequently remove the lymph glands that drain the area where the tumor is. So if you've got a tumor in the head and neck, it's some of the glands in the neck, or a breast cancer, it's the glands in the axilla, or the armpit. If it's in the abdomen, it's some of the glands there. And we generally like to treat all metastatic disease, and that's because we're trying to get to a point where the patient's at least disease-free and therefore kind of cured. So that's the sort of template for cancer surgery. So this is just a picture of a bowel cancer. So not a neuroendocrine tumor, but you can see this is actually the large bowel here, ascending colon. There's the appendix, transverse, descending colon, and there's a tumor on the right side. And so just to illustrate that first point, we would remove the bowel that contained the primary tumor, and then all the lymph glands, and the lymph glands follow the arteries that supply the vessels, that supply the area. So follow the arteries and veins. So generally that means that you're taking all the feeding and draining blood vessels at their origin, because the lymph glands will be sort of clustered down each one. And so that's commonly the strategy to manage most cancers. Now, the interesting thing for neuroendocrine cancer is we don't always resect the primary. So this is a CT scan of a patient who I've looked after now for over 10 years. I just put one scan up. I could easily put 10 up, but that's the vertebral column, and that's the front of the abdomen. This big sort of grey thing here is the liver. Liver doesn't have any tumors in it. The white things are blood vessels. The long skinny thing here is the pancreas. And the little white thing that's lighting up, that's a neuroendocrine tumor of the pancreas. So they're not uncommon. They're usually found incidentally. This person had an ultrasound to look for gallstones. And neuroendocrine tumors are typically hypervascular, so they have a better blood supply than the tissue around them. The patient here had an injection of dye. I mean, many of you will have had scans, and the dye is kind of what gives you that hot flush when it gets put in intravenously, but it outlines blood vessels in white. So the large vessel at the back of the pancreas, and that's a 1.5 centimeter neuroendocrine tumor in the pancreas. So for any neuroendocrine tumor in the pancreas less than 2 centimeters in size, we generally watch them. We do serial imaging. I've never had one in nearly 25 years ever grow enough to remove. If they present at greater than 2 centimeters in size, we often resect them, but not resecting the primary. That's the first kind of rule that we break. The second thing, and probably I suspect a number of you will be familiar with this, is when actually the primary tumor isn't the problem, but the lymph nodes involved in the cancer are the problem. And this is sort of a classic neuroendocrine situation. This is a GAT8 CT scan. Many of you will have had those either in Wellington or Auckland. And the patient's been imaged long ways. So these the patient's head and arms held up, and this is the chest cavity and the abdominal cavity here with the pelvis. The dye or the contrast agent tends to make involved tissues green to red. So here's 2 lymph nodes just there and there that are sitting alongside the vessel to the left kidney. But if we come forward in the abdomen, so that picture is closer to the patient's back, but we're now coming out a layer closer to the patient's tummy. Here's the bowel here. There's probably a small tumor here, just that little bit of green lighting up. But this patient's getting symptoms from this big lymph node mass wrapped around the blood supply to the bowel. So the lymph nodes, the area of spread is actually much bigger and much more significant than the primary tumor. So in that setting, we would do surgery to remove the lymph nodes and the primary tumor in that order, rather than to remove the primary tumor and the lymph nodes. So that's kind of the second place where we kind of break the rules. And then this is a situation where we're treating the primary tumor, but not the metastatic disease, not the disease in the liver. We will at some point, but not straight away. So these are both pictures from the same patient. This is a little bit of the CT scan on the patient. Again, there's the vertebral column. That's the front of the patient. This is the pancreas here. And this is quite a big tumor growing out of the pancreas to the point that it's symptomatic. And then you can see in the liver here, all these little hypervascular areas got a really brisk blood supply on the outside, but not on the inside. And they get called target lesions for obvious reasons. And then on the GAT8 PET, you can see there's lots of little tumors in the liver. Patient's completely well from those, completely asymptomatic. And this is the tumor in the pancreas that's causing the symptoms. So in that patient, often our strategy is to surgically treat this, and then to think about radio-labeled lutetium or one of the other liver-directed therapies subsequently to treat the liver metastases. So treat the primary, actually leave the lymph nodes, and then think about what to do with the metastatic disease. Again, we've broken another rule. I just wanted to run through some Kaplan-Meier curves because we talk about these a lot. So this is how we kind of visualize treatment effects and populations. And essentially it's a graph. So here's time in, say, months, 12, 24, 36, 48 months. And each line is a cohort of patients, so 100 in each group. This is just an idealized curve, who are all alive at time 0. The pink group gets treatment A, and the blue group gets treatment B. And so you can see by the time you get out to 4 years, the survival in the blue group is better. This is sort of how we measure the efficacy of treatment. And so here underneath, these are the numbers of people still alive at 12, 24, 36, and 48 months. So we talk a lot about survival curves. This is a survival curve, the Kaplan-Meier curves, and we base a lot of our kind of thinking on them. So it's kind of worthwhile just to run through these. So this is a Kaplan-Meier curve for esophageal cancer, not neuroendocrine cancer, but esophageal cancer. And so goes all the way out to 132 months to 10 years. And you can see very few people survive. And I put this up because of this. So as surgeons, we're sort of interested in out here, like who's going to do well, but we're also interested in here because if you get a really steep fall in survival, it means there's more deaths in the first 3 months after beginning treatment. It means that the treatment's bad. And so surgically, having an esophageal operation is quite dangerous. And so you can see there's quite a high risk of mortality in the first few months. So that's, often you just have to accept that. But if we contrast that with neuroendocrine cancers, and here's two sort of Kaplan-Meier curves looking at here neuroendocrine cancers just treated with best supportive care. So no active treatment, no chemotherapy, surgery, radiotherapy, just pain relief, good nutritional support, whether they're in the intestine, pancreas, or stomach. And you can see that the survival's pretty good. Patients survive a long time. There's not too much fall off up here. And so surgically, we don't want to bring in a treatment, a big dangerous operation that's going to have a worse outcome than these curves here. And I think for many neuroendocrine patients, that's a real risk that surgeons can get overzealous and do too much or do it at the wrong time. And then the treatment ends up worse than the condition that we're treating. If we get it right, and that's over here, so this is the same sort of patient, different patients, but same patient groups, you can see that generally removing the tumors means that more people live longer. And the fall off right up here in the first sort of 90 days or so after surgery is not too high. It's not any different from over here. So it means that the treatment's relatively safe. And this is kind of the last paradox. This is a really old Kaplan-Meier curve from a paper from the Mayo Clinic in 1970, or about 1974 it was, where patients with disease in the liver, tumors in the liver, and at that time there was no other treatment other than liver resection, which was moderately dangerous at that time. But look, the surgeons there took a relatively small number of people, so 20, 37 in each group, and this is the survival if you could remove all of the tumor in the liver, all of the tumor that you can see. And remember, it's really before good ultrasound, good CT, before dotatate PET. So almost certainly, even though they said there was no residual tumor that you could see with the eye, there probably would have been. And this is a group of patients also treated the same way, where they did as best they could. They took out 80% of the tumor that they could see. So this is all metastatic disease. And so you can see, again, broken the rule. Even if you leave some metastatic disease behind, often patients do really, really well. And again, back here, the first 90 days or so, the operations went okay. There wasn't any excess of mortality due to the treatment. So that's kind of the final paradox I was just going to highlight. So there we are. There's the fundamentals of surgery for NETs. We mostly treat the primary tumor and resect it with clear margins, mostly. We do sample and resect regional lymph nodes for staging and treatment sometimes, but not always. But sometimes the lymph nodes are the reason for the surgery more than anything else. and we mostly treat metastatic disease. We often don't treat all of it. Often we cherry pick the lesions that are causing symptoms that seem to be growing when the others aren't. And I think for me, conceptually as a surgeon, we like kind of making decisions and doing things. The challenge of treating NETs patients is it's highly individualized. Lots of MDM discussions is key. Often bring patients back to MDM 3 or 4 times. And the time frame of decision making is usually quite long, which is both challenging and good. So there's time to think about things. There's time to schedule surgery if you need it at a time that suits you. These are not tumors that are going to kill you next week. They're most likely going to be around, there for a long time. And so that's a challenge, but it's also a good thing that you have time to really think about, really plan surgery. And we have time to really think about and plan surgery too. So the first question was around managing small pancreatic neuroendocrine tumors. So I sort of touched on that. The rule of thumb is tumors 2 centimeters or less in diameter. We tend to just watch and do a scan, usually every 6 months for a year or so. And then if they're stable, and almost certainly they are, as I said, I've never had one suddenly progress. We do a scan annually, sort of alternate between CT and MRI. I do more MRIs now, although it's claustrophobic. You don't get the radiation issues with CT, bearing in mind that people are going to live a very long time with them. The other thing that I tend to do is it's possible to do, and many of you have probably seen it or had friends undergo this procedure, an endoscopic ultrasound. So that involves putting a telescope down through the throat, that's down to the gullet and into the stomach. And if the telescope's got a little ultrasound on the end of it, you can usually locate the pancreas because it sits just behind the stomach, and take a biopsy of the tumor. And so we're looking for tumors that have quite benign, pathological markers. They're not pathologically aggressive. If they are, then that would change the paradigm. But generally, the small ones are very indolent, and so we don't we don't end up resecting them, but we do end up following them usually for life, I think. Next question was recovery after liver resection. Surgery on 31/7/25. Depends a little bit on the magnitude, the size of the resection, and your overall health. Surgeons, what do we be? Paranoid optimists, I think. Everyone's out to get us, but we're sure that it'll turn out okay. So I think I do. I think I underestimate the amount of time that patients will require to actually get over surgery. It's very easy to measure the time to being okay to go home and start doing normal activities. But it's really interesting if you talk to patients. It's usually 6 or 8 weeks after any sort of significant operation, and it seems the same, for head and neck, chest, abdomen, bowel, hip, foot, heart, anything. It seems to be about 6 to 8 weeks before people feel 100%. And often when you talk to them, it's like, well, I was okay by 4 weeks, by 3 weeks, but I just feel like I'm firing on all cylinders now. And I think that that's just the physiological nature of recovery. It seems to be much the same for surgery through a big, an incision versus surgery through keyhole versus a robot, which is also keyhole surgery, because of course, although there's only a small incisions, you've still had an operation inside, and so your body is still dealing with that. So yeah, I think 6 to 8 weeks is about the norm, and I think always believe the patient. Don't believe the doctor or the surgeon. We tend to probably be overly optimistic. Net and small intestine and lymph nodes. Again, that's the classic paradigm, and that's why I showed those scans that um, often nets in the small intestine, the primary tumor is really small, often so small that you can't find it. But people seek medical attention because the lymph nodes around it become so big they cause obstruction or pain, and it's the lymph nodes that actually are where the bulk of the disease is. Why that is, I don't know, and I don't know whether the primary is big and then it spreads to the lymph nodes and then the primary shrinks. That's one option. The primaries are really small. That when they spread to the lymph nodes, they just stop growing. But either way, the lymph nodes are always the most challenging to manage in that setting. And I think we always try and remove those because they can cause intestinal obstruction, they can cause twisting of the bowel, and they can cause narrowing of the blood supply to the bowel. So whenever you eat, you get very significant pain, which is a very difficult symptom to treat. So yeah, we tend to be quite aggressive in removing those. Yeah, is surgical intervention approached differently with MEN1 patients compared to sporadic NETs? MEN, apologies if you already know this, but there's some syndromes where multiple endocrine neoplasia, MEN1 and 2. MEN1 is, let me think, parathyroid, pituitary, and pancreas. So the way we execute the operations in those patients is no different from a sporadic net in the pancreas or in the pituitary, but actually sequencing them and working out which operation to do first and how far apart for those patients. That's where the challenge is, and that's where MDM comes in as well. But in terms of the type of operations we do for those patients, they're generally the same. How does the cavity fill and scar tissue from post-open distal pancreatectomy? Yeah, I still marvel at the abdomen that we can take parts out of it. You know, we can take bowel, kidneys, pancreas, parts of the liver, the stomach, and everything just kind of redistributes. And in some cases, like the liver regrows, but sort of fills in the space. It's kind of miraculous, really, but it usually does. Most commonly, straight after an operation, the surgical bed where the operation was fills with fluid to some degree, and then the body just gradually reabsorbs that, and everything kind of just redistributes into that space. It doesn't stay a space; it gets filled. A question on after surgery care. Yeah, look, I continually learn about this from my patients. I think we surgeons tend to be very hospital focused, and so we're quite good in the hospital at getting people back on their feet. But really, the real nitty gritty with care starts once you're you're able to eat, you're able to move, you're able to take care of yourself, but you're still on maybe some pain relief and some other things, maybe some nutritional supplements, and that's where the really hard work starts. And I think that's the most of the 6 to 8 weeks is kind of as getting all that right. What I often tell my patients is get a multivitamin, just something really simple, Myodeck or Centrum from the chemist, not too expensive. That's useful because if your body needs vitamins or trace elements, it will take out whatever it needs, and you'll just pass the rest. So that's a good thing to do. Eat whatever you want. Cancer patients aren't greedy people. And so if you kind of wake up and think, man, I'd really like an ice cream for breakfast, as my mum says, that's in some way that's your body telling you that it needs something in the ice cream. So just be kind to yourself for the first sort of 6 to 8 weeks or so. Listen to your body, do what it says. Be prepared to have a rest in the middle of the day, and that'll start off being a nap. And it'll generally just go to reading the paper in a chair. I think doing some exercise every day is good. It's good for your body, certainly, but good for your head as well. Just have a little goal. And it might just be, I'm going to walk to my letterbox and back, or I'm going to go to the park. I often suggest a park, particularly if there's lots of benches, because then you can walk from bench to bench to bench to bench and have a rest, and take someone with you. And then it's like, well, I'm going to skip a bench and sit at the next bench. And so you can gradually stretch it out. And the only other thing I'd say is getting better is not a straight line. The line goes up, but it's sort of jagged. One day will be good, the next day will be not quite so good, but after that it'll get a bit better. And the lows won't be quite so low, and the highs will get higher to the point that you'll just end up forgetting to take pain relief, and it'll just slip back into normal life. But I think it's a full-time job getting over any of the any of the treatments that we provide. There's a question about what's new and exciting in our area of expertise. So there's a new treatment called histotripsy, which involves using ultrasound, focused ultrasound, to kill solid tumors. It was developed in Asia, and it literally just ultrasound, like diagnostic ultrasound. It doesn't require an incision or a needle passed into the tumor. You use a computer to focus the point of ultrasound in the middle of a tumor. So it's very good for treating liver tumors, probably pancreas, probably kidney, certainly endometrial, so uterine tumors, and probably stuff like thyroid, when because it's relatively new, but we'll find new roles for it. We have there's a foundation based in Hong Kong that we met with at the university last week, who are interested in providing, actually putting 3 histotripsy machines, 2 into Sydney, Australia, and 1 into here. So literally today, our lead interventional radiologist has gone to Hong Kong to see how they use it. I saw it about 3 weeks ago in Bangkok. But patients do require general anaesthetic for it, but there is no incision, and there are no needles being passed or anything like that. And it does seem to be extraordinarily successful in treating solid tumors, particularly in the liver. So that's kind of what we're excited about at the moment. I think there's a very real chance that we'll have that service next year available. Yeah, fascinating question. Absolutely, there is, and it just reflects, I guess it reflects how complicated an organism we are, and how, many NETs secrete hormones that we can measure. The ones that, like, NETs that secrete insulin, thyroid hormone, pituitary hormones, and they all affect our cognition. They all affect our mood. I mean, the classic is parathyroid tumors, which change our calcium metabolism, and a third of those patients actually present with psychiatric changes, not any other physical changes. But there's far more things secreted by NET tumors than what we can measure. And so, we can probably measure about 15 different substances, hormones, whatever you want to call them. But I think NETs make all sorts of things that affect people's cognition, affect their emotions, affect their emotional stability, their resilience with anxiety, all sorts of very subtle changes. A colleague of mine, Janice Paseka, who's a surgeon in Ottawa, has a whole research project around this, and measuring people's psychological profiles before and after surgery and how surgery improves them, even though the net is supposedly non-functioning and not secreting anything. I think it's an absolutely fascinating area, really. I mean, it would be surprising, right, if they didn't do that when you think about all the things that nets do. The challenge with liver mets is that there's simply so many ways of treating them, and which is good and bad because we're spoiled for choice, but we still don't yet know in each patient what the optimal sequencing of treatment is, and often the optimal timing of treatment. But roughly, treating liver mets is divided up into removing them or most of them. So that's a liver resection, that's an operation. But then there's a whole lot of other things which are called liver-directed therapies. So that's where the tumours are not removed, but they're otherwise rendered inviable. So histotripsy, the new thing that I just mentioned, that uses ultrasound waves to basically shake cells to death. So they vibrate so much in the ultrasound that their cell walls shatter and they die, and it's very effective. We use a lot of ablation, which involves putting a needle through the skin into the middle of a tumor, and then that needle has a small microwave emitter on the end of it. And depending on how much current and how long, you can essentially cook a sphere of tissue of variable size around the end of the needle. So if you put that into a tumor, you can destroy the tumor with heat. So we do that a lot. We also use embolization, which relies on the fact that remember I said the tumors they're very dependent on an arterial blood supply. They're bright white in the liver, white in the pancreas, white in the bowel. And so if you interfere with that blood supply, that leads to those tumors dying. So we will simply embolize tumors, particularly in the liver. That just means that we put some gelatin or some other biological substance into the artery or arteries that's feeding the tumor. We often combine that with chemotherapy. So we'll put chemotherapy down the artery into the tumor, and then we'll block the blood supply. Or you can do the same with little spheres that contain an isotope. So you put those into the tumor, block the blood supply, and then the isotope is a beta emitter of radiation. So within 1 to 2 centimeters of where the spheres are, they irradiate the tumor and cause death in that way. So there's quite a lot of different ways of dealing with liver tumors. We also transplant very occasionally. Patients with metastatic NET to the liver undergo liver transplant. It's rare, but in the order of 1 to 2 every 5 years in Australasia. Oh yeah, good question. Strictly speaking, well, look, what I do is I generally see people for a little while afterwards, more because I'm worried about complications from the operation, infections, strictures, something like that. So I'll follow people up for that. If it's a truly benign tumor, I generally give the patient the choice. If 100% it's not going to come back and it's not associated with any other condition, I'll give the patient the choice of whether, they just want to talk on the phone every couple of years, so a very low-key follow-up. And about half of people accept that, and half of people are like, no, look, I'm fine. I'll get in touch if I need to. For neuroendocrine tumors, we generally follow people for life, just because, it's such a complicated thing, and there's often the risk of other tumors happening. The components of follow-up, the clinical follow-up, I really enjoy that, even if it's just getting an email from a patient or talking to a patient briefly on the phone, and try and do that to stop dragging people into hospital. Imaging gets a little bit more complicated, again, particularly for neuroendocrine tumors, because people are going to live a long time, and if they have a CT twice a year for 20 years, that's an awful lot of radiation. So we need to be cognizant about when we image people and how we image people as well.
There's one here that asks, do NETs run in the family?
Yeah, in some syndromes, yeah, they do MEN 1 and 2, and a couple of other syndromes. The majority of people, well over 90% of people with NETs, it's just a sporadic thing, just happens. For
Um,
those familial syndromes, there's now genetic testing that's available, so you can be quite kind of clear whether it runs in the family or not. Yes, yeah. The miraculous thing about the liver is it regrows. So whatever you remove, the liver will increase in volume equal to the volume that you took out. So yeah, it's quite possible to have multiple liver operations over time. Yeah. It's very individualized. Any other cancer diagnosis, the answer would be absolutely yes or absolutely no. If you would have the primary treated, or if it was palliative, then you definitely wouldn't. NETs is such an interesting area. So I for the NETs that I see, which are generally GI NETs, so really stomach, most commonly small bowel, pancreas, occasionally large bowel. My bias is to treat the primary tumors. And you say, well, you're always going to get a haircut if you go to the barber, and surgeons used to be barbers. But 30 years ago, when I sort of started training, there were a lot of patients who had scans that showed tumors in the liver and a tumor in the bowel. And one of the prevailing philosophies at that time was, there's no need to treat the bowel tumor because, the patient's not going to survive very long because of the liver mets, which if it's a large bowel cancer or a pancreas cancer or stomach cancer, of the other sort, that's quite possibly true. But, patients survive decades with disease in the liver, often needing a little bit of treatment here and there. But I saw so many people who were, really in severe pain, nutritionally really compromised by primary tumors in the bowel, that my bias is to remove them, if we can localize them. The liver disease, we generally we think about that a bit more, not because we don't know what to do, but it often moves slowly. And there's so many different ways of treating it, and often the treatment is multiple different ways. And the fact that we've got lutetium labeled octreotide lutate therapy here, that's been a real game changer too for liver disease. So tend to compartmentalize things a little bit. So treat the primary tumor, inevitably, I'd say, if it's symptomatic, if it's affecting the patient's quality of life. If it's a 2-centimeter tumor in the pancreas and not, well, we're going to watch that. Yeah, I generally would. I work in a hospital with a great biopsy unit. Just because if you're going to watch it, it's really nice to know that it's right at the benign, the non-aggressive end of the spectrum. If it was technically not possible or dangerous, then I'd be happy to do an earlier scan. So maybe do a scan after 3 to 6 months just to see that it's not growing. But we're very lucky where I work. We have great endoscopic EUS surgeons who are very good at getting biopsies safely. That's not the case throughout the country, and I understand that. So I wouldn't say it was inevitable. I'm just lucky that I can do that. No, there's a couple used. The one we use a lot is called Primavist. They're mostly iodine based, so people who are truly allergic to iodine, often need steroids or sort of anti-allergy treatment beforehand. But no, they're not at all toxic to the liver. But I've never had contrast, but I've seen patients have it, and the thing that everybody talks about is it's like having a hot flush when it gets injected. They know when it goes in. Yeah, great question. This is where you get into the if there was only one sort of treatment, it'd be really easy, but there's a whole lot. Um, the one of the reasons we go slow is we're looking to see what the biology of the disease is. So if the lesions are growing quickly, then that sort of sets your gear for how you're going to treat them. The vast majority, more than 99% move quite slowly as a group. So it's quite useful just to watch. So you'll often, the net MDM that Ben runs, people will go through that and then come back after say 6 to 12 months and have a scan reviewed. And that's not deliberate inactivity. That's just getting a sense for what the growth rate is or for the liver lesions. The second thing is that not all tumours are the same. You think they would be, but sometimes, there'll be 12 tumours, but only one will grow. And so then the question becomes, well, what can we do for that tumour that will stop that one growing? And, with as little impact on the patient as possible. We'd love to resect everything, but that's a week in hospital. It's a general anaesthetic. It's an open operation in most cases. And so that's got a cost for patients. And that's where, embolization, radiofrequency ablation, microwave ablation, lutate therapy, hopefully histotripsy, and those like really good value treatments, but minimal or minimized impact on patients are really, really good. The other thing that we look for is the underlying liver, the health of the underlying liver. Is there cirrhosis? Are there other things going on? Generally in neuroendocrine patients, there's not. Chronic liver disease isn't a risk factor for neuroendocrine tumor at all. I think as a surgeon, I've said this before, but the main challenge is kind of gearing the timing to what's the biology of the disease. Does all the disease need to be treated now, or just a few spots, and making sure that our treatments aren't worse than what we're treating. Because the risk benefit discussion is very different if you've got, say, pancreatic cancer and your expected survival is without treatment is only 2.5 months. That's very different. But the majority of neuroendocrine patients, even with liver disease, are going to live for years, multiple years. So we don't want to do anything that's going to needlessly shorten that. But equally, you do want to maximize the treatment benefit. I can't remember it's very common. It's fascinating. The desmoplastic reaction, particularly around those lymph nodes that I showed you in association with a small bowel net. You don't get that around the primary tumours. It doesn't happen with the primary tumours, but it does happen in the lymph nodes. And we call it desmoplasia because really when you look under a microscope, there's just lots and lots of scar tissue. Huge amount, often, in lumps that you can hold in your hand. We don't know what the triggers for that are, but there must be a molecular trigger within the tumours when they get to lymph nodes that causes that to happen. You don't really see it in any other setting. And yeah, you can mistake that for adhesions. And that the clue is that they're the worst adhesions that you've ever seen in the world ever, and you wish that you were somewhere else when you're trying to divide them. That's the clue that it's more than just adhesions. I often cheat on this because I often say to patients, right at the beginning of the consultation, what questions do you want to ask me, as opposed to me starting off. because patients often come, really well informed, and they've often read widely, and they've got quite a good idea of what they're sure of and what they're not. Um, I guess the thing that I really hammer with neuroendocrine tumors is, I use the phrase, this is something that you'll die with, not of, because I think people come very much with a cancer diagnosis, and well, small cell tumors can be really, really aggressive. The majority of neuroendocrine tumors are not. They do grow, but time is measured at the very least in months, but usually in years, and most commonly in decades, in my experience. So I think that's a big thing for patients to get their head around, that, you're not going to die next week, but also that this is a long-term, for the most part, not, problem that's going to be with you your whole life. So you kind of have to change gear. It's not just going to be a select, a treatment, and then everything will be fine after that, and we'll go back to normal. No, you'll still be doing normal, but you'll probably have this diagnosis with you your whole life. So I think that's really important. And then the other thing that I try and emphasize, and we've sort of done it tonight, is that unlike many, many other cancers, there is a bewildering array of potential treatments for this. And I haven't even touched on radiation or SABR or brachytherapy, or all the different chemotherapies that Ben and the oncologists can, Sharon and the oncologists can talk about. So that's both good, and that there's lots of treatment options, but it's also a challenge because there's lots of treatment options, there's lots of choice, and then it's a matter of getting working out the timing and the sequencing of those. So the first conversation, I try to really emphasize those points, stretch out the timeline, make it really clear that people have got lots of time to make up your mind. You don't have to, even if you decide to have surgery, but you want to have it in February next year, that's fine. If it, really, biologically, if it isn't, I'll tell you, but for the most part, you have a lot more autonomy, I think, as a patient. There's a lot more choice, but it's probably bewildering. And then it's all the usual things, what are the risks? What are the potential benefits? What are the aims of treatment? Have you done it before? How many of these have you done? Have you found it? Is there any other patient that's had what I'm having? Could I talk to them? That's always really useful. Yeah, nutrition after a Whipples is really interesting. Generally, I would say not muscle loss. One of the things the pancreas does, it secretes enzymes that help digestion. So for the most part, we send our patients home post-Whipple with those digestive enzymes in tablet form, pancreas. So take 1 to 4 or 5 tablets after a meal, depending on the size of the meal, just to help with absorption, predominantly of fats. I think it harks back to that question about surgical recovery. If you talk to a Whipples patient, it's 6 months before they feel 100% again, not 6 weeks. They're usually okay by 6 or 7 weeks, but the spark, the joie de vivre, the get up and go, is honestly 6 months, and there's pretty good psychological testing data that proves that. And it doesn't mean that people are not tough. It's just such a massive operation with, six joints, 5 joints. And it takes a long time for your body to adapt to that, I think.